up here, but I'm going to walk a little bit. So it's really an honor to be here. I was here several years ago, back in 2010. Was anyone here at the conference in 2010? Good. So most of you are probably more new than that. So first of all, congratulations on your courage to come into a session that's called palliative care. It's a scary word, and I think people have some misconceptions about it. And my hope today is to deconstruct those myths and misconceptions and convince you that palliative care is for everyone who has any sort of an illness, who's navigating their way through a medical universe that we live in right now. So that's really my hope, is to break down that fear that comes with the words palliative care. But I'm just a little curious about what you hope to get out of this morning. We're kind of a small group, so we can be a little bit more interactive. I have a zillion slides. I talk very fast. We'll get through them. But in the meantime, what are your hopes this morning? At the end of this hour, what do you want to walk out of here thinking or knowing or feeling? I need a brave volunteer. I know you're all brave. Yes? Great. So I'm going to broaden that a little bit. So help talking to your child about difficult decisions. It could be a DNR, but it could also be a lot of the other difficult medical decisions that you face along the way. Great. Anyone else? Okay, it's not that early in the morning. Yes?
I think I fall under the category of having a misconception and the fear about it. So I just am here honestly to just become more educated and get proper information.
Okay. So. Well, I hope that we will definitely accomplish that this morning. Anyone else? Yes?
We've kind of recently started with the palliative care group, and I guess in my head I'm partly here also to understand kind of what that path looks like over the period of disease progression.
And what? Okay, great. And where are you?
Colorado.
Okay. At Children's in Denver, or? Yeah, okay. Anyone else? All right, well, we're going to go through all of this. We're not going to necessarily talk in detail about how to have that conversation, but certainly I'm available. I'm going to be here all through tomorrow giving the same perspective of a talk for people who are facing palliative care as an adult or transitioning their adult kids. So if you see me and you want to have further conversation, I'm happy to do that. In the meantime, we're going to whiz through some of these things. I'm here for many reasons, but not the least of which is, I don't know if any of you know the Lyman family, but I had the honor of caring for Caroline Lyman for a good part of her life. She was one of my teachers about mitochondrial disorder. Her family, Marty, her dad has been on the board of UMDF, and her family sponsors my appearance here, so I want to thank them. And I got to know Caroline early on in her illness journey, when her entire life had basically been spent in the hospital. She had spent only a few days of the first 7 years of her life at home, which caused great struggles for her family, most notably her younger sister, who had no life because the family was always in the hospital. And one of the things that our palliative care team was able to bring to the Lyman family was the ability to go home and stay home. And we knew Caroline from the time she was 7 until she died at almost her teenage years. And in that time, she spent a total of 5 days in the hospital after she had spent most of her first few years. And so that was our journey with Caroline. It's not everybody's journey, but she continues to teach me to this day. So anyone know where Akron, Ohio is? Oh, good. So I don't have to give too much of a spiel here, but most people don't. They say Acorn? Akron? Where's that? So anyway, most of you maybe know that we have a famous basketball player there, but we're actually known for a lot of other things as well. So I thought I'd teach you a few things. This is kind of what it looks like half the year in Akron. But so this is your time to shine here. So this is an audience participation question. Which of these things is not from Akron, Ohio? Hopefully you know the answer to this, right? Okay. But the real answer is that all these things, these other things are from Akron, Ohio. So my goal here is to make it possible that when you leave, it will be impossible for you to say that you did not learn anything today, because you might have learned something about things from Akron, Ohio. So which of these things is not from Akron?
Cookies.
Which one? Duckies?
The Girl Scout cookies.
Girl Scout cookies. Anyone say oatmeal? Marshmallow Peeps? Dodgeball. Hillary, you're from Akron. Which one does not come from Akron?
I think no go that way.
Okay. So it's actually Marshmallow Peeps. They're made in a small town in Pennsylvania, but everything else is made in Akron. Okay, so again, you learned something. We're done here. Let's go eat lunch. No, I'm just kidding. And there are a whole host of other things that I think is fascinating about Akron. I actually live in Cleveland, Ohio, which is not that far away. So we're kind of in a Northeast Ohio cultural extravaganza with all kinds of interesting trivia. So you can go home and amaze your friends with your trivia knowledge now. Okay, so what I'm really going to do today is talk about what palliative care is and is not, why it's different from hospice, why we should all have palliative care, what it looks like, what the language is, and then some of what you asked about, which is sort of the trajectory or the path or the things to be thinking about and asking about when you're on this journey. But what I really hope you hear is that this is not about death and dying. It's not just about pain management, although that is part of what we do. And the earlier we get to know you and your families, the better we can be as advocates. Someone was just sharing with me that they have a friend who met palliative care when their child was 9 months old and is now 4, right? And so during that time, a lot of stuff happens, and it's way easier for me as a palliative care practitioner to meet you, get to know your family, know what your goals are, and walk that path with you, than to wait until someone says, oh, wait a minute, things aren't going well, time to call palliative care. And then I come in as the new person you've never met at the absolute worst time of your life and say, hi, nice to meet you, let me help you navigate this difficult thing. And you look at me like I have 5 heads, rightfully so. So the earlier we get to know families who are struggling in any way, the more helpful we can be. We made a documentary several years ago, and we also made a module of that documentary, which you can actually get to on the UMDF website. Features Caroline and her family. It's about palliative care and mito. But the main movie that we made is a 55-minute long documentary. It follows 7 families who had their journey with us. And one of the families talks about when they first heard about us and they first met us, they went, palliative care, we don't want that. And after about a year, the mom says, you know, who wouldn't want that kind of care, right? So once you get in, you figure out that we're not people that are here just to give your child morphine and hasten them to their end of life, but we can actually be very helpful. Your perspective can change. And it really, I believe, should be a standard of care for most people who are going through any sort of serious health illness. If I were very sick, if my child were very sick, this is the kind of care that I would want. And only by having people ask for it and demand it is it going to become sort of standard of care, so that no matter where you are in the country, no matter who's taking care of you, you should have access to high quality pediatric palliative care. We're not there yet. We're a lot farther than we were when I started in this business 20 years ago, but we have a ways to go. So this is a question for you. Okay. Remember when you were in school and they said when you take a multiple choice test, the longest answer is always the right answer? So that's the case here. So we are not the other things. We are an interdisciplinary team. I'm going to tell you a little bit more about as we go forward. And this is what we do. Okay. So it's commonly thought of as being something that is, you know, akin to death, but really that's not what it means. Palliative actually means to cloak or to comfort. So we like to think of ourselves as a big hug for people who are going through a tough time. And really any treatment can be classified as palliative. Chemotherapy, surgery, anything. So it doesn't mean that you're not going to have certain treatments if you have palliative care on the journey with you. Okay? This is a definition that actually was created sort of by the American public in a survey study that was done several years ago now. But basically what I've highlighted here are the important words I want you to see. You don't see anything that says terminal. You don't see anything that says you have to give up your providers that you love and the medical care that your child needs. This is together with the disease treatment that you're getting for your child or yourself with mito. And it's about improving your quality of life in all sorts of domains, not just the medical domain, but your emotional and psychological and spiritual domains as well. For your other kids, for your lives, for your marriage, for your relationships, for your community. Care for everyone. So this is kind of the official definition. It says the same thing. It's holistic care, and it's a method of care. It's not a place. So sometimes people will say to me, well, where's your unit? I say, well, my unit is wherever the child is that I'm taking care of. So sometimes that's in the home. In Caroline's case, it was in her house. Sometimes it's in the school. We go to an IP meeting to help navigate that journey. Sometimes it is in the hospital, but it's not in a specialized unit. It's wherever your child is that you want your child to be. So what does that really mean? It's just comprehensive care. Now, yes, we do take care of people who die. Unfortunately, children die and people die every day, and unfortunately, people with mito die. But a lot of people are walking around or getting around with and learning to live with their diseases or live in spite of their conditions. And that's really what we're there to help with. We can be helpful at the end of life when those things start to come up or those conversations need to be had. But our focus is on empowering the family to take better care of yourselves and your child. Or another way to put this is that we're about creating beauty out of what's a very fragile and can be very delicate and difficult situation. So this is sort of the same thing, except I want to tell you that our definition of palliative care is complex, chronic, and or life-threatening. Okay, so that's MITO. Complex, chronic, and or life-threatening is MITO, right? So we are here to help you live as easily as you can. And a big thing that I do and that my team does has to do with information being given to you in a way that you can understand it, that your child can understand it, and that you can make really good decisions for your family. Because at the end of the day, what we want is for people to be able to look back, no matter what the outcome, and feel like you made the very best decisions you could as a family, as parents, and that you can live with the consequences of those decisions. Most of you are very young, meaning that any decision that you make now, you've got a lot of years to think about whether it was the right choice. And we want people to feel like they were given the right amount of information in the right way at the right time to make good decisions. I'm an oncologist by training, and in my cancer work, we have seen a huge switch in the amount of information that is given to families. It used to be that the doctor went in and told you what you were going to do and didn't give you any opportunity to agree or disagree. Now, our job is to walk in with a consent form that's about this thick and say, hi, your child has cancer, I'm really sorry, here's some paperwork, read through this, let me know what you want to do, I'll be back. And that puts an incredible burden on you. And it's not fair. What we really are going for is partnered decision making so that you have the information you need and you understand it and you can provide true informed consent. Because I think a lot of times it feels like this to you, doesn't it? Does this look familiar to your lives, right? So my job is to help shut off some of these lights, take them out of the picture, and help you see where the green lights are and which way you want to go. Okay. This is a kind of a complicated graphic, but I wanted to just put it up here, and it's based on cancer, but instead of possibility of malignancy, you could just put mitochondrial disease there, because I think what happens is when you get a first clue that something is wrong with your child or yourself, your whole life changes, right? The life you thought you were going to live, the life you thought you were going to have for your child, your reality gets fractured. And you go into sort of a state of limbo where you're not knowing, you may be waiting for a diagnosis, waiting forever for that gene test to come back. Really? Does it take that long? Right? And you're feeling very worried and vulnerable, and you're kind of very emotional and going through this turmoil. And then eventually, we hope, you get to some sort of new normal. Maybe it's quick, maybe it's not. Maybe some of you are still looking for that elusive new normal. But that's a process of reconstructing your whole reality, not just for you and your child, but your family and the grandparents and everybody else. And there's a whole lot of tasks that occur along that way, such as managing the flow of information, right? Who are we getting information from? Oh my gosh, there's so much on the internet. What do I even look at? What do I believe? How do I assign meaning to this? This is not what I thought my life was going to look like, and so on. And so our job is to help guide you through that. Okay, so it's also not a lot of these things. This is my friend Amani, and Amani is a lovely, bubbly young girl who loves her palliative care team, and she is telling you that we are not about giving up. And in fact, we have graduates from our palliative care program who end up doing very well, and they don't need our services anymore, which is absolutely lovely. So she's telling you it's not just about these things, okay? So it's also not hospice. A common question I get is, what's the difference between palliative care and hospice? And hospice really will tell you a lot of the same things I just told you, but there really is a time limit inherent in hospice. There is no time limit in palliative care. I've been running our program in Akron for 16 years now, and I have patients in my program that I had the day I opened our doors. So we follow some of these families for a very long time. Some of them do die, some kids die, some families lose their children, but for the most part, we are there for a long haul. And that's the biggest difference between hospice and palliative care. Okay? So one way to put it is that all hospice is palliative care, but not all palliative care is hospice. That sort of helps. Am I going too fast? I'm from the Midwest, but I talk more like I'm from the East Coast. So, okay, so what do we actually do? We do pain management. And some of your kids with mito have pain. Some of them have a whole host of other symptoms. And we also are expert in managing many of the other symptoms that go with a lot of diseases, mito included. But in order to be a good palliative care doctor, I need to be good at all these things. And what I tend to focus on is not just is the symptom there, but is it actually causing you distress or your child distress? Because sometimes you can end up putting kids on a million medications to take care of symptoms that are not actually bothering them. And then we create a whole host of other issues. So that's partly what we do on the physical side, but we do a whole lot of other stuff that's non-physical care. And this is what I was talking about earlier. The care of the child, the family, the community, the grandparents. Kids have goals, right? Just like we do as adults. They have goals to achieve certain things. And we want to achieve those goals in the way that they want them to happen. So really this is a focus on life and living, not on death and dying. So it takes a village to do this. I think you probably could tell me more than I can tell you that we have a bit of a problem in our healthcare system right now. That might be news to some of you. But when they did a study a number of years ago and asked families what the #1 complaint was with the healthcare system, even after their children had died, the #1 complaint was fragmentation of care. Feeling like you don't know who to call about what, you have to go over here, these people don't have this record, when you go over here, they send you here, your left toe is broken, so you go see a different person than when your right toe is broken. I mean, we have a bit of an issue. And when you have a kid who has an organ system disease that affects a whole lot of different things, you can end up having your care very fragmented. And we also have kids who are scattered around. I mean, it's great to have all these folks here at this meeting who are from all over the world, but in any given community, you can be the only person, the only family whose kid has mito. So finding people who know about it and who know how to take care of it can be challenging. I don't need to tell you that. This is a picture, it doesn't project all that great, but this is actually a picture that was drawn by a mom of a girl whose first name begins with G. And what she did was to diagram out all the pieces, parts involved in her child's care. This is what fragmentation looks like to her on a daily basis. That's overwhelming. I mean, you need to be a child's full-time case manager to keep all of that straight, let alone spending time with your family and having fun and taking care of your other kids. So that's the problem that we're up against. We also know that many folks who are on this journey don't know how to navigate it. You haven't planned for the unplanned medical expenses. You don't have, piles of money sitting around to take care of things when your child is really ill. If we do get to the point of needing to plan a funeral, nobody has done that for the most part for young kids who have died and so on. And then a bigger problem that we're seeing now is that because our supportive care is so good, patients are living longer, which is great. But then they're transitioning out of their pediatric health systems into adult systems that go, we don't know how to take care of you. Right? Has anybody faced that issue yet? Yeah, got a couple people. So it takes a village to raise a child. And essentially, we want to be part of that village. Takes you a minute, but you get there. Okay, so this is what families want. I don't need to put this up in front of you, but this is actually what's in the literature about what families want. And I've said a lot of this already, but one of the biggest things that families want is that our healthcare providers are all talking to each other, right? Do you get tired of telling the same story to 50 different people who appear not to have talked to each other ever? Yeah, okay. So that's what we're trying to fix. So really, the other thing that we're trying to fix is to keep you home. As I mentioned in the beginning, Caroline, her family's biggest complaint was that they spent their entire life in the hospital. And that's not where kids want to be. It's not where you want to be. It's not where the rest of your family wants you to be. So if home works, that's also something that we can be helpful with. And I also know that people want to leave no stone unturned in the quest for a cure for their child or at least better medical treatments. So again, this is concurrent care. It's not either or. Palliative care does not mean choosing, oh, we're going down a palliative route or a comfort care route, or we're going to get everything that we get when we choose an aggressive medical care. It's partnership. And I've said that about 3 different ways because that's the most common misconception that still persists out there today. If I select palliative care, it means I have to say goodbye to everything else. No. If somebody tells you that, they don't know what they're doing. Okay. So the way that we describe our program in Akron is this, because I've just said a lot of words with a lot of slides to explain palliative care, but what we found is that it works better to sort of put it in visual form. And what we talk about with families is, this is very corny, but go with me here. So what we want to do is give you a canvas, and we want to give you a bunch of paint pots on that canvas that are a variety of different disciplines or specialties, people with various kinds of training who can help you at various times in your journey. And we want to give you a paintbrush, and we want you to dip that brush into all the paint pots that make sense for your family. So you may need a lot of medical care and not a lot of the other stuff. You may need a lot of social work and spiritual care and not a lot of medical care. Your picture of quality of life for your family is going to look different. Everybody's picture does. But if we give you the tools and the colors, you get to create that picture. Okay, super corny, right? But it helps explain it, right? Okay. So what about MITO? Well, you know, let's be honest. There's most definitely an altered life trajectory. We know that many people with MITO live many years, and many people, in fact, don't know they have MITO. But for kids who are diagnosed early, who have a significant disability with MITO, there may be an altered life trajectory. We also know that you're going to end up seeing a lot of people in a lot of different places. There are some places, which is great, that are now evolving to sort of multidisciplinary MITO-focused care, but many people don't have access to that kind of care. We know that it's devastating on any level. This wasn't the life you picked or planned, and the finances, again, become a huge issue. And we know there are lots of opportunities for decision-making along the way. So those are the things that, if you wanted to put big buckets of things that palliative care could be helpful with, in addition to pain and symptom management, I think these would be probably the most common things. So when do we see patients? Well, not every patient with MITO needs to have a palliative care team involved. There are many of you probably, or people that you know, again, who may not even know you have MITO. And a palliative care team may not be what you need. But if you're starting to see that there are significant symptoms that are happening with you or your child, or if the diagnosis is really severe up front, or there's decline, you're seeing some changes over time, or you're facing difficult decisions, those are the kinds of things where you should be thinking to yourself, I wonder if palliative care could be helpful, and asking about it. So MITO, as you probably know, follows lots of different trajectories. And again, just like everybody's palette picture is different, everybody's MITO course is different. And yes, we have some buckets where we can make some generalized predictions, but for the most part, every kid is different, right? There are some common themes, though. This is kind of a schematic of the usual course of somebody with a cancer diagnosis. And I put this up here because this is how the Medicare hospice benefit was created, which then spawned the field of palliative care. And the basic idea here is that you have some health status on this axis, and then time is going past on this axis. So when you're first diagnosed, you have good health. You start out here, you're doing pretty well. You go through treatment, your health doesn't, it suffers a little bit. Hopefully you get back up to your previous level of good health and you go on. But if your cancer comes back or something's not going well, you generally can kind of go down this path to death. So that's how the federal government created the Medicare hospice benefit 30 years ago to pay for palliative care or hospice care at about here, right? So the reason to put that up here is this is not a common trajectory for MITO, although it can occur that way. The problem is that the systems that were put into place, the payments, the teams, the structures, are all based on this, which is not what your life generally looks like. There are a number of other trajectories that can potentially occur, and I don't know why my slides are not. There we go. So often MITO looks like this, right? It can be a chronic illness that has periods of relapse and remission where you kind of maybe get back up to your previous level of health, and kind of time goes on. Okay, it can look like this, where it's a chronic progressive illness, where again there are those issues that happen, and each time something happens, a bad pneumonia, a new neurologic problem, you don't get quite back up to the baseline where you were before, and when you look back 5 years, you realize there's been some decline, okay? So that's another possibility. And generally, palliative care, the arrows that I'm showing sort of is where historically palliative care has gotten involved with families, and the second arrow is sort of where we really like to get involved. This is another potential trajectory of decline some of you may have seen, where there's really kind of a progressive, inexorable course that goes with the diagnosis, and there are certain times along the way where there are decisions that you're going to be making as a family or new levels of support that are required for you if your child or you is progressing along this way. So my point here, and this is another one as well, you may actually be doing quite fine. Your child might be doing quite fine, can barely even notice that anything's wrong, and then suddenly something happens, a bad viral illness, surgery and the anesthesia and the consequences of that, and down you go. So all of these things create a lot of uncertainty, and it makes it difficult to figure out, well, when would palliative care be appropriate for me and my family? So I'm putting that up there so that, you know, maybe this matches some of your life. Maybe it doesn't. Maybe you have a totally different trajectory. But what makes that difficult is when will that decline occur, if it's going to? Of course, when I'm saying this, we're hoping it's not. But let's just, our motto is kind of planning for the worst and hoping for the best. So let's talk about what the possibilities are, and then we'll be ready if and when they happen. And if they don't, great, let's all celebrate. But if we don't talk about this, you end up in a situation of chaos, and you end up with people who have not had any conversation as parents or with their children about what they might or might not want, and it just is not a great time to make really significant life decisions. So the more that you can be honest with yourselves and each other and your families and your physicians and your care teams, the better prepared you'll be, and hopefully you'll never need it. Right? So if you have all the flashlight batteries and canned soup and everything in the basement, maybe you won't get hit by a tropical storm. Okay. So these are sort of the things that are challenging. Again, you might want to add to this list, but when you start to see that things are not going as well as you want them to go, prediction is hard in kids with mito, as it is in kids with any disease, right? They're fine one minute, they're not the next, and then they're fine again, even when it looked like they weren't going to be. Or they were fine, and then they weren't, and then they're never fine again. I have a young lady I just saw the other day. We've been following her for a number of years now. She has chronic pain, and she was doing pretty well, and she went to the mall one day, and she sat in the chair in the shoe store to get new shoes, and she never walked again. She sat down in that chair at the mall. They tried on new shoes. She couldn't get up at the end of that, and she has never been able to walk again. It can be that sudden. And so there are these things that happen that are really unpredictable. Maybe you have someone in your family that's more than one person. Maybe you've got 2 family members that you're dealing with. And then these other things that can be very, very frustrating for you as you go through. Have you ever wondered if you were imagining things and wondered if your healthcare providers actually believed some of the things that you were seeing and feeling with your kids, right? So what do we actually do? What can palliative care be helpful with? So I'm going to go through various categories of things. There are physical things that we can be helpful with. Many of your states have waivers, some don't, some have insurance benefits for these kinds of things. But thinking about the way in which we can make your child's physical environment the very best that it can be to minimize strain and fatigue and help them function as well as possible is part of what we do. And that includes optimal nutrition. Hopefully you're all involved with dietitians for your kids who know mito and who know how to maximize energy metabolism, because that's really important. The other thing that's really important that most parents never do is respite care, right? Take a break, because you're in this 24/7, 365, and it's a long haul, especially if your children are doing well and they live for a long time. That's what everybody wants, but it can be exhausting on caregivers as well. And there's a lot of data coming out now about your own illnesses as caregivers and the toll that it takes on people. And people at the beginning think, oh, this is, you know, I've got this. This is my job, I'm a parent. And then 10 years in, when you realize you've got your own chronic pain and other issues, it becomes harder. So I'm just saying that to plan for trying to figure out ways to give yourself breaks along the way. I mentioned that we do physical care as well. There are obviously many organ systems involved, and the timetable is unpredictable, and it varies among every kid. So we have seen a big change, I think, in the last 10 years of the recognition of mito and people playing better in the sandbox. But there are still folks who are very reluctant to prescribe for kids with mito. They don't kind of know what they're doing. And some of what we do prescribe for mito is not proven. It's not exact. But we know anecdotally, or we at least want to give something a try. And so that creates angst in the medical profession, because people like to see things that are in the New England Journal as a randomized controlled clinical trial, right? How often does that happen in mito for the medicines that you're using for your kids? Not often. So that's some of the issue that we can help navigate on the palliative care side of things. We know that the mechanism of mito are not well understood. I can't tell you how many times I have gone to schools to talk to teachers and guidance counselors and special ed folks about mito. and what it means and how the kids in school need to be treated. And so I think that's something that your advocates can do for you on the palliative care team. Every time you change schools with your kid, going through that whole litany of, well, why does the temperature matter in the classroom, and why does your child need to be able to take water or snack breaks, and all those sorts of things that schools just are not aware of. So the community is often very unfamiliar. I know I'm preaching to the choir about this, but what you may not be thinking about is that your palliative care team or even your medical team could be helpful for you with this. So reaching out and saying, I'm tired of sort of explaining to people over and over again, because the changes are subtle. And people may think that you're blowing it out of proportion, or you're trying to make it easier for your child to get through. I've actually had teachers say that to me. This isn't real. They just want, they want it to be easier. Really? Okay. So, and then we do know a lot about symptom control, those of us who have worked with MITO and palliative care. And what we try to do is give you some idea of what's kind of a usual presentation, what are some of the common symptoms that you can think about, and what are some possible solutions so that you're not behind the 8 ball when things start to happen. So I'm not going to go through each of these in terms of listing them, but you know that there are many different effects on all of the different organ systems. And my job, I'm not a MITO expert, but I am an expert in palliative care and mitochondrial disorder. I've taken care of many, many children with MITO in our palliative care program. So no, I'm not going to stand up, with the physicians on the other side of this hotel and talk about all the new molecular therapies. But what I've come to know over my 20 years of doing this is what are some of the issues that are coming up, and how can I help you help your child through them? And there are a myriad of them. You know that the nerve issues are a big problem. Neuropathic pain is a big problem. And I think for many families, even recognizing that their child has pain, if you can't express it verbally, and how best to treat that type of pain without just knocking them out on a bunch of narcotics or opioid medications is part of the art of this. And again, these are probably very familiar symptoms to you. If they're not, and you're new at this, and you haven't been to many of these meetings, or maybe your child was just diagnosed recently, or maybe even isn't diagnosed yet, but you think that your child has some of these issues, these are things that we, again, point to the diagnosis of MITO. We know that lungs and muscles can be affected. We know that the heart can be affected, ears, eyes, basically any organ in the body, right? Because we all need mitochondria in all of our organs to function. So when I see a patient, or I work with Dr. Cohen and he sends me a patient, the first thing I do is to try to figure out what is happening and why is it happening. Because one of the other things that I hear from people is that things get overly blamed on the underlying condition, right? So just because your child has MITO, or you have MITO, if something new happens, that doesn't mean we should just say, oh, it's the MITO, there's nothing we can do about it, it's a progressive problem. We should be asking ourselves, is there something we could do to prevent further deterioration or decline? Is there something happening that's actually treatable, that's separate? Or is this something that we have to live with? This is going to become part of our new normal. And that's my job to help you figure out as time goes on. So again, we do pain, we do a lot of other symptoms, as well as sort of the side effects of many of the diseases and treatments that your children can be on, because we know they're on a lot of meds. Pain management is an art. It's an art for everybody, not just people with MITO, but trying to figure out where the pain's coming from. And this is, I think, where some folks get hung up on not really understanding in MITO. It's not as simple as, well, you broke your leg, there's going to be leg pain where the bone is. Why does it hurt the way it hurts? Why does your child express it that way? And what can we potentially do about it? Or is it really pain? And are they just, is something else going on? So really getting sort of at what kind of pain is it? Are they able to tell us? Is it coming from gut dysmotility? Anybody have that issue with your kids where their guts just don't work very well? The food doesn't go through normally, and so that causes a lot of distension in their guts, and that radiates nerve pain through the rest of their bodies and can basically mess up everything else. So again, our job is to try to sort that out, not just throw you on medicines. And we use a lot of non-pharmacologic pain management in addition to pharmacologic, meaning not medications, but other strategies, so that we're not just adding more medications to your child's list. So there are a lot of different medications out there that we use for pain, and my intent here is not to give you a pharmacology lecture, but just to let you know that there are things that can be done for your child's pain or your pain. And depending on what kind of pain it is and where it's coming from, there may be different strategies that we can use at different times. So it's important to be in with somebody who knows this, who knows these mechanisms, and is willing to be creative with you about how to get good symptom control. There are other things that can be done too. I think there was a lecture earlier about physical therapy and more of the non-pharmacologic. That is so important. Our physical therapist is very integrated with our team because even just simple positioning can end up preventing a lot of the issues that come down. And making sure your child is sleeping well. That's the biggest thing. People look like I'm crazy. They say to me, well, I'm here for my child's pain. And I say, the first thing we need to do is get your child sleeping well and on a good regimen. Because we all know that when we're tired, everything hurts worse, right? And it's so much more difficult to figure out strategies. I'm hearing strange noises. The killer bees are coming. And using some non-pharmacologic strategies like I mentioned. Some kids can't tolerate being touched. They have a lot of sensory issues. But other kids actually prefer that, the weighted blankets, and even things like acupuncture that can be very helpful. Next time, warn me when you're going to sneeze or the needle will go right through your head. Okay. And then help for other symptoms. So what are some of the other symptoms? It's a list that you may have seen. Constipation is a big problem in the mito population because, again, when things are not going out where they came in, that just sends all kinds of nerve and muscle signals all throughout your body and gets you all wacky. I think most of us take it for granted, but it's one of the most, it's actually fairly simple to kind of address, even though there are very refractory cases of it. I think sometimes we just sort of dismiss it, but often fixing constipation can be miraculous for families who have been struggling with a lot of these other issues. So fatigue is a big problem, falling asleep in your food, falling asleep wherever you are. And I think that's a very difficult symptom to treat. We don't understand it, and that's obviously what a lot of the research is about, is to restore the energy metabolism to give you more energy. But there are also other things that can be done if your child isn't sleeping well or is having significant fatigue. We don't just have to say, oh, well, it's the mito, they're tired. What can we do to make that better? So I'm giving you all of these things as tools or things to ask about if you are in these situations, to talk with your healthcare providers about, or ask for a palliative care consult about, and start to just sort of think through. This may all be old news for you, but more often than not, I meet families who have just been told over and over again, oh, it's the mito, and there's nothing we can do about it. So I'm trying to give you some strategies to say, well, have we thought about this? You know, why are they continuing to have these issues? So again, why? Secretions and increased drooling is a big problem in many kids with mito. There are medications that can sort of dry that up, but sometimes we forget to look for a cause. One of the most common causes for that is actually reflux, where kids' reflux is not well controlled, and they get that acidy feeling all the time, and then that creates drool, and out it comes. Same thing with constipation. It makes sense. If things are blocked down here, they're going to back up, and that includes secretions and drool. So my point here again is thinking what could be causing this and what might we be able to do about it instead of just blaming it on the disease. Okay? Many kids are anxious and agitated who have diseases that they can't, especially if they can't verbalize what's going on, and they feel uncomfortable in some ways. So figuring out what the sources of those things are, using pharmacologic and non-pharmacologic strategies for that. And my favorite here is expressive therapy. Expressive therapy is any therapy that allows you to be creative. So art, music, dance, drumming, sensory types of things that you can work with your kids. Those kinds of strategies are often very, very helpful and mean that we don't have to put kids on yet another medicine to manage their anxiety. So some of these things to think about if anxiety or agitation can't be explained by something else, like pain. Okay, so maybe it's massage that could be helpful. Mr. Potato Head prefers ketchup with his massage, but massage therapy can be very helpful if your child can tolerate being touched. Now again, some kids can't, but having a therapist who gets to know your child and knows what feels good, massage has done wonders for many of our kids with mito, and their moms and dads too. Thinking about side effects, so what we try to do here is to be very aggressive and proactive and anticipate that there are going to be side effects and help you manage them, because those are important for quality of life as well. And a lot of what I see in my medical colleagues, not that I'm throwing darts here, is that we start medications and then we forget to say, oh, well, we put you on this a month ago, is it helping? Well, if it's not helping, maybe we should take it off. And we just keep adding meds. And then by the time I see the kid, your child is on 43 different medications that you have to get up in the middle of the night and administer. And we don't even know if half of them are even doing any good. So being sure to reevaluate. If you start something, are we going to keep going or are we going to stop? Okay? And I think you may know that Mito creates sensitivity to certain classes of medications that sometimes get mislabeled as allergies. It's not really allergy so much as worsening the underlying condition. Unfortunately, sometimes we still need to use these medications. There are situations where they have to be used, but knowing that we are balancing risks and benefits is kind of what it's all about there. And then, as I said already, sort of minimizing the number of medications and treatments. So starting to ask, if your child is sort of more severely ill and is on maybe a declining path, do we need to keep every single appointment with every subspecialist? Can we consolidate some of this? Can some of the care be done at home? Can we stay out of the hospital and keep Caroline at home as the example again, so she can be a cheerleader and go to school when she feels up to it and not be stuck in the hospital just because people aren't quite sure what to do with her. So that sort of weaning or winnowing and picking the most important things as your family is having goal-directed decision-making discussions about what you want for your child. Polypharmacy is a huge issue. And I think the medical profession's finally sort of waking up and realizing the harm that comes from all the overprescribing that we do. But we've got kids that are on things that one medicine is actually directly counteracting the effect of another medicine that they're on. And the side effect that's caused by this puts them on another medicine to manage this side effect that counteracts this medicine. So sometimes families are better off just taking their kids off of everything and kind of starting all over again. And that's part of what we can do, is to help streamline that management. So this is to the point that was brought up at the beginning. In terms of, as things go along, getting to know your family, knowing who is your child and who are the other members of your family and what's important to you. And continuing to have conversations about what are we doing and why are we doing it? And does this make sense? Is this furthering your goals for your child? Or are we just doing things because we can and we don't know what else to do? And so we need to help you determine what's important for you as a family. And when we know your goals and someone brings something up, will that particular issue, procedure, treatment, medication, help you get closer to your goals or not? It's okay to say no to some of these things. I think that's also a paradox that people get into is, you're in the medical system and people are telling you, well, you need to do this and you should do that. Your child needs a tracheostomy. You're going to get a G-tube. You're going to have all these things done. And people forget that you parents have choices in these matters. When you have a child with a life-threatening condition, there is no law that says that you must do X, Y, and Z. If you want to, and it's going to help you further your goals and help your child be more comfortable, absolutely. But if this doesn't make sense for you, you have the right to say, hold on a second, what are the benefits, what are the burdens, and let's think about this before we make a decision that we're going to have to live with for the rest of our lives. Okay? So I mentioned this a little bit, but besides medicine, we work a lot with DME providers, with specialty nurses and public health nurses and folks like that to make sure that families have what they need at home. Try to provide a lot of psychosocial support, getting to know families, talking about advanced care planning. We have a session tomorrow morning in which one of my former patients' moms and I are going to talk about this advanced care planning conversation and how to have that with your child and begin to explore those things. And honestly, we should all be doing that for ourselves anyway. Everybody should have an advanced care plan, regardless of whether you have a life-threatening disease or not. But our main goal is to maintain your child's functionality for as long as we can, as well as we can. And that's what palliative care is for. Ever feel like you're on a roller coaster with this? So it's an emotional roller coaster. There are a lot of very normal feelings that come up for families, and oftentimes in the medical side of things, you don't really have an outlet for those things. So we also have people on our pallet whose job it is to help you with those things. and to balance the joy of the life that you have with the child with the grief and the anger and the frustration and the exhaustion that comes with that as a normal part of caring for a sick person. Spirituality is very important to many families, sometimes not, and that's okay too, but when we do have families who are struggling, oftentimes this is when you're seeking meaning in your life, you're trying to understand what's happening, and providing that sounding board for you and people to help you with that is also part of what we do. And then just plugging you in with some of the other things that you may need, the genetic counseling that comes with this, and case management and care coordination. Again, back to what I said earlier about fragmentation being the #1 complaint from families. So our job is to have you not be your child's 24-hour care coordinators and for us to be. Our team is available 24/7 to families. We may not be the people who can fix X, Y, or Z or even know how to fix it, but we can take that first call and make the next step for you and try to get an answer for you. Even if it's 3 o'clock in the morning and someone just needs to talk about how freaking hard it is, that's what we're there for. And that's what I would encourage you to ask for no matter where you are. So I mentioned these things already, but the siblings are often the sort of forgotten folks along the way too. And so our team actually offers a fair amount of programming for siblings, and we try to provide extra people on the team who can be that sibling's person, so they have someone else to talk to other than mom and dad, and that can be really helpful too. Not that your other kids don't want to talk to you, but sometimes having an objective person can be really helpful. And then if things are sort of not going the direction that we would hope, this is also part of what we do, and providing anticipatory as well as actual grief and bereavement support is a big part of what we do, as well as just helping you figure out what those options are and what they might look like for your family. No one wants to think or talk about this, but unfortunately it's a reality. Life is a terminal illness. I hate to break it to you, but so far the death rate in this country is 100%, no matter what we've done. So we really want to be doing this for all of us, but sometimes it gets hastened a little bit, even though we wouldn't want it. So here's the part about early is better. It shouldn't be an either or choice. I mentioned that to you early. And the idea is that I'm going to integrate with your Mito team. Dr. Cohen and I at Akron are going to work together. We're not going to be either or. And we are here to make your child, help your child feel better. So in fact, if there are treatments and things that can be done, he or she will be in better shape to go through those, right? Good symptom control, good sleep, good pain control gives you more energy. If you are anxious, or you are in pain, or you are not sleeping, you're like this, right? And think of all the mitochondrial energy you're burning. And when your child doesn't have much to start with, you're wasting it on things that can potentially be fixed. So that's partly what we're here to help with too. So I mentioned this earlier too, we don't want to meet you late when you don't want to meet a new person, and we want to be there through the whole process. And I think it should be standard of care. That's just my bias. So this is what it's really all about. We're trying to be a lighthouse for you, for people to know that there's a beacon of light out there when something like this happens, and to really be there to help ease the suffering for you, whatever the suffering looks like for you. And it may look like different for your family than it does for your family. So who are you, what is your family, and how can we help? And that's what palliative care is all about. So I just finally want to say, and we'll have a little bit of time for questions, but it's my bias, and of course I'm biased, but I think that if you have a care team that's there to help take some of the stress off, you're more capable of sort of managing things. And actually we see people do better. Oftentimes after palliative care, and even hospice gets involved, families notice that their children are functioning better, and I'm not taking all the credit for that, but just in terms of paying attention to some of those other symptoms and relieving them can give your child more quality of life. So it's the opposite of thinking that palliative care is there to shorten your child's life. And I really do think that our focus needs to be on healing. No, there's no cure for Mito right now. Maybe there will be soon. But while we're going through this, how can we help your body heal, your spirit heal, your emotional, psychosocial parts of your life heal? So once again, this is Caroline. This was her sister Abby. When we first met them, Abby is now almost about to go to college. And she, as I said, I just really want to give her credit because I learned a lot about Mito through knowing Caroline. And I think her story is a great model for how we want to be able to integrate with families and find out what's important to them and allow the Abbies of the world to grow and thrive and have their own lives too. So it's time for us to stop saying yes, but, and to start saying yes, and just embrace this model of care. So you're probably familiar with these resources, but more on the palliative care side of things, you may not be. There are some palliative care specific resources, and there's a great parent network called courageousparentsnetwork.org. Anybody ever seen that or been on it? They've started incorporating more about Mito on there. It's run by Blythe Lord, who is a woman from Boston who lost her daughter to Tay-Sachs disease, but started this as a resource for parents. And there are all kinds of different things on there about how do I talk to my child, what is palliative care, what, those kinds of things. So it's very informational. I would highly recommend that. And Blythe is also very open to feedback. She's trying to build Courageous Parents as something that is responsive to your needs. So, it's just important that whatever we do, we kind of have to, change is hard, so incorporating palliative care into the mainstream care of anyone takes time, but you can help be part of this. You can help the future move forward. This just says, my doctor told me to start my exercise program very gradually, so today I drove past a store that sells sweatpants. Okay, so we have to start somewhere. And I hope that by hearing a little bit about this and understanding what it is and isn't, you can help us be advocates out there so that no matter where kids are who are diagnosed, they will have access to these services. This is my email. I am more than happy to hear from you, you can send me questions. You can ask for resources in your area. I may or may not know, but I can usually find someone to help if you want to email me. And then I always close with this, and if you've seen me present before, you've seen this before, but this is a picture that was painted by one of our patients. She had cancer, not Mito, but back when we were talking as a team about how to make it clear to families what we're all about, we were coming up with the palette concept. And we asked Cassidy was 11 at the time, she had a spinal cord tumor, and we asked her to paint a picture of what palliative care meant to her. Now Cassidy always wanted to be an artist. She was an amazing kid, but she was crawling, before she got sick, she was crawling around on the floor of her mother's bedroom one day looking for her Christmas presents, and she found her mother's portfolio of artwork, and her mom had been a really good artist and had given up her career in art to take care of her kids. And Cassidy found that, and she that day decided that she was going to be a famous artist to live out her mother's dream. So then she got sick, but nothing stopped her. And so we asked her to paint this picture of palliative care because we had been involved with her for a while by then. And I think what you can see is obviously the palette, which fits in. And you can see that Cassidy felt sort of the warmth and the love. She also knew the sadness. She was 11, but she was 11 going on 30, and was very involved in the decisions around her care. She died 2 years later, but before she died, I bought this painting from her, the actual real painting. I paid her money for it because I wanted her to know that she was a famous artist, and we had bought her artwork. I promised her that I would show it wherever I speak. And she was amazing in many ways, but not the least of which was this is the first watercolor she ever painted. And also, and I always cry when I say this, but she was right-handed, and the tumor paralyzed her on her right side, and she painted this with her left hand. And so this, to me, is palliative care, and this, to me, is why I do what I do. And I hope that we can all get strength from Cassidy. And with that, I will stop, and I'm happy to answer any questions. If you want to friend us on Facebook, we put a lot of stuff on our Facebook page about families and support and things like that. So, yes?
Would you mind going back? There's a few slides I'd love to see again. First, your email address, and then prior to that, there was one that had the courageous, what was it?
Courageous Parents, yes. Courageousparentsnetwork.org is one word. Oh, okay. Sorry about that. So it's just all one word, courageousparentsnetwork.org. And this is my email. And thank you very much for your attention today. Do you have any questions? I think we have time. She didn't bring the big hook out to pull me off the stage. Yes?
I guess just kind of broadly curious on maybe some of your experiences and perspective in the past with where, like, kind of bringing the non-immediate family into the fold, just successful strategies for that, challenges. I mean, we've run into some challenges with that, I guess, so I'm just curious.
Challenges are, yeah. The challenges, I think we could all illuminate the challenges of non-immediate family and people who want to weigh in decisions and be involved and have updates or not be involved. I think that's really tough. And I think what I always say to families is that family is who you define it as, and not to waste your precious energy trying to be things to people especially during your times of need. And so we find out who our true friends and family are when things like this happen to us. Having said that, you can't 100% dismiss biology, right? So there are people who still feel like they are. I don't know, are there particular things that are troublesome? I mean, sometimes it's about just managing the information, and so people use things like Caring Bridge pages and things like that, so they don't have to update the 50,000 people that want information. Sometimes it's about people who feel like they should be part of decisions and they really don't have any right to be. And then the opposite, where you actually need help kind of in the village that you're taking care of, and that more, yeah. And, you know, that's where directly asking would be my first thought, because sometimes what I've heard is that, you know, people have said, well, you know, my mom won't step in and help, and then we've actually kind of had a family meeting and the mom will say, well, you never really told me directly that you needed help. They were sort of assuming that people would understand that they might need help. So sometimes just getting it out in the open, if that conversation can be had, and I've facilitated those kinds of conversations with families. So you might want to try a family meeting, but if that fails and people are still not able to, then turning to other family, church family, neighbors, friends, people. And what also helps is coming up with specific things that you need that they can be helpful with, so that people don't have to be imaginative about that. You know, I really know, you know, I know you're uncomfortable taking care of my son so I could go have a night off, but you're awfully good at mowing the lawn. Could you do that? You know, so giving people something concrete that they can do, but not expecting them to do things that they're not comfortable with. Does that help? Sort of, it's difficult. Families are tough. Did you have a question? Yeah.
Yeah, I'm happy to report right now that my daughter's we've got something going with palliative care in Kansas City, but it's been a long, frustrating road where it's been recommended by doctors for years. We could never get it, and it's the same story everywhere we go in the hospital, whether it's where we live or where she's going to school and happens to be in the hospital all the time. I think palliative care is, you know, it's wonderful. It's here today. It's great, but it's kind of the way of the future where all the hospitals are advertising and promoting, and they want to say that they have it.
Yes.
It is the latest, greatest thing, and so important. People are living longer, but they have chronic life-threatening illnesses. So we need to be able to provide these services. So the hospitals are all saying they have it, but they're giving it a really bad name, because we just ran it in Kansas City, run it in just Nebraska recently, where the doctors had recommended they put in a consult for palliative care team, and it got shot down right away. They said, oh, sorry, she's not a cancer patient, she's not end of life, and she'll be walking. It's only for cancer patients, end of life, who won't be walking out of the hospital. I'm like, wait, excuse me, that's not palliative care, that's hospice. That's what we're finding everywhere, and they don't. And if they do have it, they're fortunate enough to have it. Say Kansas City, for example, it's a very small program with one person, not a doctor, just a psychologist, just for pediatrics, just for the cancer patients.
That is a big issue, is access, and that's one of the reasons that I'm exhorting all of you to ask for it, because I think what it's going to take to change that paradigm in this country is grassroots demand for these services. The reality is that palliative care programs and services are not well reimbursed in this healthcare system. So every place that wants to set up a palliative care program, the question is always, well, what are the finances behind it? And when they start looking at that palette that I showed you, most of the people on that palette don't bill for their services. So, you know, our program has grown largely from the hospital supporting it and from philanthropy, from people in the community who really believe that we need this kind of care. But in many places, that's the actual hard reality. And the problem is that in order to be on the US News and World Report survey that comes out about the best children's hospitals in the country, you have to have palliative care. So everybody says, yes, we have it. We might have a psychologist or a nurse. But in order to really push levels of quality, things are changing. So, you know, the Joint Commission has certification for palliative care now. We have hospice and palliative care standards from the National Hospice Organization. Things are coming along. But you're right, it's lagging well behind. And what it's actually going to take is, just like you guys have gotten the sort of the medical community to pay more attention to mito is families to stand up and say, why don't you have this here? And even to go so far as to say, well, I'm going to go to another hospital that does have it, because that's what changes things. Because until our payment structures change in the United States for healthcare, and we don't have time to talk about that because I know you all want to go eat lunch, but until that really changes and we start paying for what we value instead of paying for what we do to people, procedures, it's going to be very difficult for systems to build in-depth programs.
We're actually out of time, so.
I'm happy to talk afterwards, but I know I'm standing between you and the food, so thank you very much.